Hello, everyone, and welcome. Thank you for joining us for today's webinar, where we will be talking about residential service staffing obligations, including mandatory care minutes and the 24/7 registered nurse responsibilities. My name is Janet Anderson. I am the Aged Care Quality and Safety Commissioner, and I will be chairing today's webinar. I'd like to start by acknowledging the traditional owners of the lands on which we're meeting, wherever you are in Australia, and pay my respects to elders past and present, and extending those respects to any Aboriginal and Torres Strait Islander people who are joining us for today's webinar. I would also like to warmly welcome the people with whom I'm sharing this webinar as my fellow panel members. And I have joining me today Peter Edwards, who is the Executive Director Compliance Management in the Commission, Dr. Melanie Wroth, who would be known to you, many of you, our Chief Clinical Advisor. Danni Campbell-Manley is joining us from ACCPA, where she is the State Manager for Victoria, and also for the Q&A session, which will bring the webinar to a close, we are joined by Thea Connelly, who is the First Assistant Secretary, Home and Residential Division in the Ageing and Aged Care Group within the Department of Health and Aged Care. Whew. Okay. Topics we're going to cover today include the Commission's approach to case managing providers who are not meeting their workforce obligations. Melanie will talk about alternative clinical care arrangements when providers such as you may experience gaps in your registered nurse cover. And then we're going to get some insights from Danni in relation to what ACCPA has learned and shared with providers in relation to innovative practices employed by providers to meet your workforce-related responsibilities. As mentioned, there will be a Q&A session at the end of each of the panelists' presentations. So please store up your questions and send them through the live Q&A tab that you should see on your screen. We've also received a fair number of questions in advance of the webinar, and I will be doing my best to ensure that we get through as many of them as possible. We are recording this webinar, and we will be sending a link to all of you after the webinar, and it will also be placed on our website. And my final housekeeping note is that there will be a survey for you, which pops up at the end of the webinar. Please take a moment to complete it. We are always interested in listening to and paying attention to the feedback we receive from our webinar participants. And we're also asking in this survey for your ideas as to the topics you would like us to cover in our 2024 series. So please stick around for the survey, complete it, send it in, because we will be very pleased to hear from you. Now, I'm going to make a few opening remarks before I hand over to the panel members. As you would all know, mandatory care minutes took effect from the 1st of October this year. And what they did was introduce to the sector, to residential services across the aged care sector, a sector average of 200 minutes of care delivered to each resident every day, which includes 40 minutes of registered nurse care for all residential services. Now, that would be well known to all of you, I'm sure. And what we've understood, and I'm sure you also appreciate, is that new mandatory care minutes target is very complementary to the existing responsibilities to have a registered nurse on site, on duty, around the clock for all residential services. Now, it may not have escaped your attention that what we came to understand fairly quickly was that the sector was performing very close to those requirements even before the introduction of the RN cover requirement and the mandatory care minutes requirement. And I'm not going to go into the detail of where the sector was operating. The Minister has made announcements and it has been covered in the popular press. But registered nurse on site, on duty, over 98% of the time across all residential services is a really creditable result. There's not that much difference between 98% and 100%, and I know that there are some services that continue to work towards that. And similarly with the care minutes targets, it's not the sector-wide average is not that much shy of the expected sector average of 200 minutes per resident per day. And frankly, I think you deserve accolades for that. I think the sector is already there or thereabouts, with a little more lifting to be done and some support that the department and indeed the Commission might offer by way of guidance and educational tools and so on. We are very much aware of the challenges that the sector faces in attracting and retaining a sufficient number of appropriately skilled staff. And we certainly understand that those challenges tend to increase the further away you are from a metropolitan centre. So we're very alive to those challenges, and we have said and we've put in writing that the Commission will take a fair and sensible approach to regulating compliance with these new requirements. And I hope you've read our publications on this, which could not be clearer about this fair and sensible approach. We will always seek to understand in the first instance your operating context and the effort you are putting into securing and holding on to the necessary staffing complement, and always delivering the clinical care and general care, the personal care that your residents require. It is only in circumstances where that comes apart and where there are significant shortcomings that we start to get very exercised, because what we see is a profile of escalating risk. And Peter will be talking about the approach we take, which at every turn is informed by the efforts that you are putting in and your capability to deliver on the commitments that you have made and are making to your residents. Now, we have put a fact sheet out about alternative clinical care arrangements, which is very material for all of you reaching for the 24/7 RN cover. And Melanie will be talking to us about what appropriate clinical care arrangements looks like, and particularly in those circumstances where you may be struggling to fill every single shift with at least one RN. I've just turned 2 pages. And as I mentioned, Peter will be talking with us about the compliance approach. We also have with us Danni Campbell-Manley, who will be talking about some ideas that are being gleaned from the sector in terms of ways of reaching for these responsibilities, fulfilling them to the maximum extent possible. That's about as much as I want to say by way of introduction, which is effectively the prologue to the work that each of the panel members will now do. Peter, can I invite you, please, to talk with us a bit more about the Commission's compliance response to providers as they seek to work to fulfil the workforce-related obligations?
So thanks, Janet, and good afternoon, everyone. It's I'm really glad to have an opportunity to talk about this topic, as I know from speaking to providers, some of you are anxious to understand how the Commission will respond to non-compliance with these types of obligations. As Janet's mentioned, our primary focus as a Commission is on ensuring residents receive quality, safe care that meets their needs. So we do maintain an interest in compliance with both RN coverage and care minutes, because it's, I think, well understood that having the right mix of clinical and non-clinical staff available when residents need that care supports delivery of quality, safe care. So the Commission will actively monitor care minutes and compliance with RN coverage. And our reason for doing that, and I think this is a very important point, is the very same reason we analyse all the other information we receive or collect. And it's because it helps us make decisions about which services we should look at more closely, either through desk-based or site-based assessment contacts. Because it's through those contacts with services, it's through that we check whether things like care minutes or RN coverage, when considered alongside all the other information we might have about a service, are posing a risk to quality and safety of care being delivered to residents. Therefore, any regulatory action by us will be based on our assessment of whether risk to residents are being adequately managed, and not whether there is strict adherence to RN or care minute targets. Now, in our experience, the key to managing those types of risks where workforce availability is a problem, and Melanie will be talking more about this later, starts with having a suitable workforce strategy. A strategy focused on optimising how staff are used across the day so residents have access to the people with the right skills and experience when needed. We find that providers that are doing that are generally able to demonstrate risks to residents caused by workforce availability issues are being appropriately managed. And where that's shown to be the case, there is no reason for us to consider taking any type of compliance action. That said, we may continue to undertake some form of monitoring activity from time to time to ensure we have visibility of any change in the risk level flowing through to residents. Where we have serious concerns about safety and quality of care being delivered to residents, we will intervene regardless of the underlying cause. What that intervention looks like will depend on different factors. For example, where there's immediate and severe risk to residents and an absence of any evidence from the provider that they are actively seeking to manage that risk, we do need to often take urgent action to safeguard the interests of residents, and that's usually through some directive action by us under a notice to agree. Putting that aside, in all other cases, the action we take is governed by our assessment of the provider's commitment to work with the Commission to manage the risk. Now, increasingly, the Commission may, for example, with the agreement of the provider, adopt what we are calling a supervisory approach in circumstances where we do hold concerns about risk to residents without necessarily resorting to use of our formal regulatory powers. This means we will engage closely and regularly with you as a provider to ensure you are managing risks and doing everything necessary to address workforce gaps that are potentially exposing residents to a higher than acceptable level of risk, including putting in the sorts of workforce strategies that I mentioned before. Any escalatory action we may take from there, such as imposition of sanctions, for example, will be informed by the level of commitment and progress the provider makes towards putting in place controls to support the delivery of safe, quality care for residents. So, although the decisions we make about taking compliance action are based on our understanding of risk to residents, in which things like workforce obligations feed into our understanding of that risk, we do want to see evidence that all providers, regardless of the resident relative risks, do have a plan to eventually meet their care minute and RN coverage obligations if they're not already meeting them. Now, as Janet mentioned, we are acutely aware of the workforce supply issues that are impacting many of you, and that those supply issues are more pronounced in some areas than in others. Therefore, we do take those factors into consideration when assessing the reasonableness of a provider's planning around how they are looking to attract, recruit and retain the staff they need to be fully compliant. So in summary, we do look at compliance with care minute and RN coverage, and we don't look at care minute and RN coverage in isolation. Where we do take formal regulatory action, it is based on our understanding of how workforce gaps are translating into risks to residents. Except where there is immediate and severe risk that requires us to intervene more immediately for some reason, there is a bit of latitude around how we will engage with you around these sorts of issues. Although compliance is focused on the management of risks, we do ultimately want to see that all providers have a plan to eventually reach their targets, and that plan is fit for purpose for the location they are operating in. Thanks for that. And back to you, Janet.
No, thank you, Peter. All right, I am sure that there will be questions, so stand by. But before we get there, I want to invite Melanie Wroth, the Commission's Chief Clinical Advisor, to talk to us about this thing called alternative clinical care arrangements. Now, this is something that comes up in the consideration of 24/7 RN cover. And as you know, there are exemption provisions, but even for services who haven't sought or secured an exemption, they may experience some challenges in sorry for that noise, in managing their coverage of nursing staff. And Melanie is going to be talking to us about what the service should contemplate in that circumstance. Thanks, Melanie.
Thank you. So I just want to go back to the basics, really, in looking at what a registered nurse does do in terms of adding value and quality care, and helping to deliver what consumers really expect as a matter of trust. And when an RN is not on site, how are those things being done? So what an RN does, and I'm sure I'm not telling you anything new, but oversee and deliver routine clinical care, provide care to residents who need high level or complex care, and oversee the monitoring of all residents so that any change or clinical deterioration can be detected, but also assessed appropriately and an appropriate response and plan developed. And then to escalate and access support and emergency services if needed, and be able to communicate the clinical setting to whom they are escalating it. So what is routine clinical care? And think about this in terms of your current resident cohort. So clearly medication administration, and there are obviously legalities around that as well. Continence and bowel care, pressure care, wound care, clinical observations, behaviour support, nutrition and hydration, psychosocial care, diabetes, end-of-life care, the use of special devices such as drains, catheters, nebulizers, concentrators, tracheostomies, NICI pumps, suctions, etc. I'm sure you could name them all. And then, of course, there's maintaining appropriate documentation. So in order to detect a problem, that means that the person has to be able to, and the nurse would be able to, detect when observations are deteriorating or becoming problematic. So it's not just recording them, it's actually understanding what they mean. And that's in terms of fever, blood pressure, pulse, ECG, saturations, responding appropriately and assessing somebody who falls, understanding what's happening for somebody who may not be eating or drinking and the risks associated with that. If somebody's injured, let's say they get a skin tear with bleeding, if somebody is getting pain and is distressed by that, somebody's got a change from normal where they're not themselves or not right. And then, of course, there's delivery of first aid, making decisions about when and to whom to escalate emergency services, etc., and communicating these issues with families, etc., as well. So when a registered nurse isn't there to do this, what's happening in your service on that shift for your particular consumers? So you do need to think about, I would say, at quite a granular level when you're considering what your alternative arrangements are when there isn't an RN there. And obviously some of these will be just an extension of what's already happening when there is an RN there. But you need to think about your specific consumers and the skills and knowledge and experience of the current staff that you're using as the clinical lead when an RN is not on site. And they will obviously not always be the same person necessarily. So consider the what ifs. And I'm just going to give you some really specific examples that you can use to check whether your alternative arrangements are working. So what if Maury, who's receiving end-of-life care, gets worsening pain? What if Harold with COPD becomes short of breath? What if someone collapses or falls? What if Joseph has a diabetic hypo? What if Saeed gets injured and is bleeding on anticoagulants? What if Flora needs to use special equipment in special circumstances? What if Artie has one of his frequent epileptic fits? What if Boris has another choking episode? What if Mary with complex behaviour support needs becomes acutely agitated and aggressive? So what's going to happen when you don't have an RN on site to these people? And really that clearly needs to bear in mind the alternative workers' skills and abilities. So, you know, I'm sure it's common sense really that you'd be rostering your most experienced enrolled nurses and the ones that you have the most faith in their capabilities when there's no RN available. But that's always worth checking that it's fit the current purpose. Staff ability to identify deterioration, their knowledge of how to escalate this to an RN and their willingness to do that. Their skills in first aid, and of course not just ENs that can have first aid, any layperson can have first aid. So the first aid capability of the site when an RN is not on site is important. And the knowledge and familiarity of the staff that you're using as clinical leads or alternatives in terms of familiarity with the residents and familiarity with your facility and its systems. And then, of course, there's the capability of the off-site alternatives. So is an off-site RN, they're not all the same. So what is their training and experience? And crucially, I think that any incidents that occur during when an RN is not on site, it's really worth having a close look at whether you're picking up any gaps or shortcomings of what your on-call or on-site, sorry, your on-call arrangements or your on-site staff capability, which really goes to risk management and quality improvement and managing what's happening. Other areas, obviously, that providers need to consider is how remote their service is from emergency service, like ambulance services, and what happens in the meantime if there's a delay, and also how reliable their technology and telehealth skills and staff capabilities are, so that the people who need to use it are supported to be able to use it, and how providers make sure that residents and family or representatives are included in these consultations. As Janet said, we've got a fact sheet which covers a lot of this information in actually quite a lot of detail. I think it's quite a good read, but it includes how to plan, it includes governance, it includes some examples and some case studies of where providers have managed their alternative arrangements. And so just from a regulatory point of view, we expect providers to be able to evidence that their alternative clinical care arrangements are fit for purpose, that it's not just rostering a name, that you've actually thought about the setting, and to be able to describe how the care needs of each consumer, of all consumers, are still being met, including those requiring higher level and complex care. So that when an RN's not on site, the care to these people is not being compromised unduly. And of course, these things will all be taken into consideration, including the efforts in determining how effectively providers are managing these risks to consumers, and therefore the proportionality of our response to that. Thanks, Janet.
Okay, thanks, Melanie. Again, another content-rich presentation which has generated some questions we'll take at the end. Just a quick note, the fact sheet that Melanie and I have both now mentioned is available on our website and you can access it there, but I also understand we'll be sending you a link to it when we send you a link to the recorded version of this webinar, so you will have ready access to it. Now, I'm very pleased to introduce the third of our three speakers, Danni Campbell-Manley from ACCPA. And Danni is going to talk to us about some of the interactions that have already occurred between ACCPA and providers, which have demonstrated some insight into innovative ways of addressing this particular set of challenges in relation to workforce supply and ensuring that the right staff are on shift at the right times, providing the sort of care that residents have a right to expect. Danni.
Thank you, Janet, and thank you for the opportunity to be at today's webinar. I guess first up, as an industry, we prioritise the safety and wellbeing of elders each and every day, and this is all in context of an unprecedented nursing shortage, and these shortages are well understood as a result, I guess, of that ageing population, global impacts and demand outstripping supply. And recruitment and retention issues have been particularly problematic because competition is very high across the whole healthcare sector. And funding and viability constraints have further impacted these challenges. But as we know, our elders deserve the highest standard of care, and it's our collective responsibility to address the clinical risks that may arise when that nursing demand is surpassing the supply. And these shortages can challenge the safety and quality of care. Now, we definitely acknowledge that reality, but we are in a privileged position of hearing how industry is working collaboratively to find solutions to mitigate those risks. Now, first up, I guess our providers are explaining to us that clinical governance is pivotal to ensuring that they are confident to mitigate risk, even in the face of those complex workforce challenges. Clinical governance is key because it makes for important outcomes such as high quality of care, it prioritises resident safety, and it emphasises a culture of continuous improvement. And we're seeing our boards and executives tell us that they are prioritising and having a focus on error prevention and adverse events. Organisations are utilising evidence-based practice and partnering with universities to inform care. Providers evaluating the roles of mentors, educators, trainers, and quality coordinators. And our members are telling us that these roles are really essential to embed in their services, but we do need to ensure that these roles are properly funded. We know providing adequate support systems such as mentorship programs do help retain nurses, including enrolled nurses. And ACCPA does offer 3 nursing transition programs across Australia. There's a pathway for graduate registered nurses, one for graduate enrolled nurses, and a third for registered nurses that are transitioning from other areas of healthcare. The program's also very important because it does tackle some of those misconceptions that can discourage entry into aged care, and participants learn that aged care nurses lead and contribute and coordinate to multidisciplinary teams. They have diverse and impressive clinical skills, and they do manage complex and chronic disease processes. I guess the next point isn't surprising, and that's that providers are embracing technology, and that it's technology that's helping to bridge the gap and that workforce gap. There are many examples, but some are the smart monitoring systems to electronic healthcare records, and technology is streamlining a lot of processes. Telehealth and virtual consultations have been critical in ensuring timely reviews, but also to assist a provider's capacity to draw on advice from specialist nurses, medical practitioners, and allied health professionals. Wearable devices are being used to provide real-time updates on health data, such as sleep patterns and vital signs. Homes are utilising thermal imaging devices to assess skin and wounds to provide, again, that real-time data to specialists. Then via video conferencing, those specialists can help guide care. More elaborate programs, such as the Victorian Virtual Emergency Department, have been crucial in managing workforce challenges. These programs operate 24/7. They're open to all Victorians, and it's the first of its kind in Australia. The initiative provides a specific triage point for residential aged care health professionals with direct access to our public hospital emergency units, and that way accessing emergency doctors and nurses directly. The initiative has been particularly successful for rural, regional, and remote providers. Autonomous mobile robots can now transport food, laundry, assist with waste, replenish housekeeping supplies, even disinfect. And this allows resources to go into spending greater time with residents. The next area I guess we'd like to focus on, and that our members are telling us clearly, is that it is housing and accommodation to attract and retain staff that's a game changer for meeting compliance requirements. There are issues across all of Australia, including metropolitan areas, especially given the extent of the housing supply crisis. Members report many local solutions to address this, including the use of independent living apartments, building on vacant blocks that they may own, temporary housing, or negotiating with local landlords to assist. An existing government grant for aged care has also included staff housing, and this is welcome, but we do encourage national solutions across all levels of government to broker or partner on accommodation to house health and aged care workers, including migrant workers. We're also seeing private sector initiatives that are really imaginative and innovative, providing solutions, programs such as Housing All Australians. The next areas are very key. That's workforce along with funding. We get a lot of input from our ACCPA members who are seeking our support, whether that be from an advocacy point of view or to specific programs. This is really understandable when the majority of operational expenditure is on labour, as we are a human services sector. Our members have a range of creative and innovative ways they're attempting to tackle this crisis, including in regional Australia, where they are especially vulnerable. Sometimes it's a very much a layered response, and it is complex, but it's sometimes those simple single initiatives that can generate great responses through to complex suites of solutions. I won't be able to do justice today to all the things that we're privy to seeing, but for examples, you've got milestone recognition programs, award ceremonies, cultural celebrations, providers even doing fortnightly massages, other providers that provide meals for staff members when they're unwell, or if they're caring for members of their family that are unwell, assisting in that way, through to housing options and retentive incentive programs. I thought I'd share with you some statistics that I think are really lovely to understand how much ACCPA members and their residents value aged care workers. So we had over 10,000 visits to our Aged Care Employee Day website. Over 1 million older Australians used the following words to describe their aged care workers. Words like compassion, dedication, commitment, and caring. And there were 29 million media impressions in the lead up to Aged Care Employee Day. We want to work with government, the Commission, key sector stakeholders and workers, anyone who wants to assist our members address the workforce crisis for elders now and the elders of the future. By fostering collaboration, we can work collaboratively and collectively to mitigate risks and clinical risks in particular, and ensure our elders receive the care they deserve and our providers are supported to deliver it. Thank you, Janet.
Well, thank you, Danni. There's lots to chew on there. Thank you very much. I may come back to you on a couple of those points. That brings us to the end of the presentations, and now we'll move to the question session, and I'm pleased that we've got enough time to do justice to a number of the questions which have come in. And just to remind you also that Thea Connelly from the Department of Health and Aged Care is joining us for the Q&A session to pick up those questions which are directed towards the department. But I'm going to start, Peter, with you. And there's a line of questioning which is seeking further clarity on our approach to non-compliance. And some of the providers are asking, what if we keep trying, but we come up short, that we're not able to secure the necessary labour, whatever category of aged care worker, whether we're looking for nurses or ENs or personal care workers, but we're just falling short of the mark, and that continues for some time. What is the Commission's disposition in that regard?
Look, thanks, Janet, and it's probably just a matter of me recapping probably some of the things that I said during my bit of the talk. Look, our response is always risk-based, so we talk about being a proportionate risk-based regulator, and so what that really means in practice for us is that we direct our time and energy to where we think it matters most. And where it matters most for us is where we're seeing potential risk to residents. So for those providers who may not be meeting these targets, but are otherwise being able to demonstrate that they are seeking to manage the risks through some of the strategies that Melanie talked about and also Danni, so that the shortfall that they might have is not translating into a risk to residents, then as I said, there'd be no reason for us to take any formal regulatory action. Now, there are, of course, going to be times where there's a lack of strategy and the gaps are serious, and that is translating into risk to residents. Then we will obviously engage with that service and provider, and what we're interested in is what the provider's doing about it, because if there is harm being caused, and we're not satisfied that a provider is taking the management of that risk seriously enough, then we may direct action, and that will be in the form of an NTA where there's immediate and severe risk, because we ultimately want to safeguard the welfare of residents. But really, where there is higher risk, as I mentioned during my talk, we are engaging often now with providers outside of using our regulatory powers, where a provider is willing to work with us and engage with us closely, and demonstrate to us an ability to that they are putting in place the right sort of controls to mitigate the risks we're seeing. And when that risk reduces, then so will our regulatory interest in that provider. So I suppose my main point here is that when we think about workforce and workforce availability, that is just another lens that we use to understand potential risk at that service. And we look at that alongside everything else we know, and we will be motivated by the level of risk we are seeing rather than technical compliance or non-compliance.
Thank you, Peter. That's a nice segue to the question I want to put to Melanie now in relation to clinical care. Melanie, Danni talked about clinical governance as being key to a form of assurance. And it doesn't go to the selection of a particular RN or to whether an RN is coming in the next shift or not. It goes to some higher order issues in relation to oversight and policies and procedures and the training that is in place in a particular service. And I just wonder if you could sort of explore that with us a bit more, al fresco, as a question without notice, because I do think that's also material. It's not just that there is an RN available either on-site or on call. That RN has to work within a particular context. Do you just want to explore that briefly?
Yes, certainly. And nobody in aged care is working in a vacuum, and the systems and policies and human supports that are around a person is absolutely crucial to supporting the work that everyone does. And so governance obviously starts really at the top, where the board and management will set expectations. They will set their interests. They will show that they are interested in getting things right and making sure that where things are not going well, that they know about it straight away and that they can work to rectify it, that they expect to hear about things, and that there are clear lines of responsibility as to who's overseeing what and who's going to respond to what when something happens. And so all of that really goes to workplace culture, where somebody who doesn't feel, and we all have a responsibility in our clinical practice, that if we feel we're outside our scope of practice or that we're unable to do something, that we don't have the skills to do something, that we are free to say that, and that we will then get both the support and the education that we require. And then governance also looks at where things are working well and where they're not working, and that would be at again getting down to quite a granular level, that the alternative arrangements may work very well when somebody's on call, and not when another person's on call. They may work very well when somebody's rostered on and somebody else rostered on to cover that gap may be struggling. So it's overseeing all of that, making sure that the policies and procedures are up to date, that they're actually being used, that people know about them, and that they are working, so that it's looking also at the relationships with other people, that where you're expecting an off-site person, whoever it may be, hospital, a nurse that you're contracting, whatever, that they clearly know what the expectations are and what they're dealing with. So it's all of the things that oversee what is supporting the clinical care.
And if I may, a supplementary question, the relationship between governance, clinical governance, and the governing body. I'm assuming, and this is, sort of leading you into the answer, but your premise in the answer you just gave is that there's someone who's paying attention and is taking charge of those issues for the service as a whole.
Yes, and that person will be quite variable. So the lines of responsibility and communication are quite clear in a very small service. They may be quite complicated in a large service, particularly where the governing body or the board is at a large provider level, and then management is at a service level. So clearly identifying who does what in each service is really key to that. And each service will have its own culture, and we definitely see that with the same policies and procedures in place and the same systems in place, that the culture can be very, very different. And attention to culture is where a lot of your eyes and ears and safety lie, actually, where you're enabling people to really do their job properly. And culture, of course, goes to job satisfaction and people feeling safe in their workplace, and going to retention of staff. So good workplace culture has a lot of benefits.
Okay. Thea, I'm going to come to you. Unsurprisingly, we're getting a line of questions in relation to enrolled nurses. And this has been a topic of ongoing discussion since the introduction, I think, of the target and then the mandation of the target on care minutes. Can you step us through the arrangement and the extent to which enrolled nurses do feature, and just try to navigate some of the complexities of this to be as straightforward as possible about what's in and out of consideration when we're calculating care minutes?
Thanks, Janet. Happy to, and thanks for the invite to come along today. So a little bit of background, as Janet said, the Royal Commission did not recommend a specific target for enrolled nurses in relation to care minutes. But it did recommend, and government has required, that care time delivered by enrolled nurses is included in a service's total care minutes in order to allow them to flexibly decide the most appropriate skills mix to meet the care needs of residents living in the home. And partly that was informed by the fact that use of enrolled nurses across the sector is quite variable. And so the Royal Commission did not specify in a similar way that it did for registered nurses that specific target. We know, and we've definitely heard some stakeholders raise concerns that the absence of that mandated subcomponent of the care minutes target has led to an unintended consequence, such as providers substituting personal care workers, potentially, or assistants in nursing for enrolled nurses from their staffing skills mix. And so I'm here today to outline a couple of things. First of all, to make it very clear that government has been funding providers through the ANAC funding model to meet their care minutes requirements, which includes funding to employ enrolled nurses in line with providers' existing legal obligations to maintain sufficient and appropriately skilled staff to meet the needs of residents in care. And that's what we're all here to do. Enrolled nurses are a vital part of this mix. And so the other thing that we have introduced to maintain some visibility of providers' use of enrolled nurses is that we've now started publishing enrolled nurse care minutes alongside star ratings on the staffing page via the Find a Provider tool recently, just from October 2023. Now, very clear, this is not the government mandating care minutes targets for enrolled nurses. However, we consider that the publication of this information will provide a greater level of transparency to the sector, as well as to residents and their families on the use of enrolled nurses in residential aged care.
Okay, well, thank you for that. That certainly brought a lot of clarity. I'm sure there will continue to be questions, but it's good to have that level of detail available to us. Thea, you mentioned star ratings, and I might take you there next. The star ratings, as we know, contain one of their 4 components is a staffing component, which draws on the reported care minutes. And a concern has been expressed by providers that if they fall short of their care minute target, that may count against them and draw down their overall star rating. And the questions come, is that going to be reviewed? Is there any prospect that there will be an adjustment of the star ratings algorithm to take account of services which are trying but not always succeeding to achieve their care minute target?
Yeah. So star ratings is obviously a very important initiative. It is it's quite new. And as you said, Janet, it's complicated it's calculated based on a complicated algorithm that draws from a range of data sources. The main data source for care minutes data feeds into that staffing rating. It's provided through the quarterly financial reports across registered nurses, enrolled nurses, personal care staff and assistants in nursing. The other categories include residents' experience, compliance and quality measures, but staffing does represent 22% of the overall star ratings, and it is based on that case-adjusted target derived using residents' ANAC funding. So it is tailored for each approved provider and each residents. So yes, we are undertaking an evaluation of star ratings this year. That will include consideration of the current subcategories, including staffing. The staffing rating continues to provide really important transparency about the performance of the service, but it also really importantly supports providers to uplift their care delivery through nationally consistent benchmarks. So in undertaking any review, we're also conscious of the fact that we do need to maintain a measure of consistency, but equally we want to make sure we're giving the best information, the most transparent information to the people that we're hearing really value the star ratings.
No, fair enough. Thank you. That's useful to understand. Third question for you, and this may be the last for you, inevitably tracks towards funding. Some providers are saying through the question lines that they are incurring unexpected costs in engaging agency staff where other staff are unavailable to them. And they're putting the question, is that something that is going to be recognised in the funding arrangements going forward?
Yeah. So we do know that there is a place for agency staff to fill short-term vacancies. Government is obviously encouraging providers to employ enough permanent staff to meet their requirements, as we know that that's directly linked to better quality care. And don't need me to tell anyone that it's also less expensive, obviously. To support providers to meet costs associated with requirements that I've just talked about before, around care minutes in particular, there has been a significant amount of funding since 21-22 when the reforms did start. A very large number, it's $6.2 billion, which does flow through directly through the ANAC funding model, but also through the 24/7 registered nurse supplement. And I might ask the convenience conveners if you could perhaps make sure we can send around the link to the 24/7 registered nurse supplement so that people can have access to a bit more information about that. But essentially, as well as that $6.2 billion, we did see following the ACCPA, the Independent Health and Aged Care Pricing Authority's recommendation to government did decide to commit an additional $10.1 billion in ANAC funding to implement a new ANAC price of $243.10 per resident per day, as well as to fund the 15% Fair Work Commission wage increase for certain aged care workers. That's to reflect actual costs since ANAC was introduced on 1 October last year. We are expecting that government will make further decisions based on and informed by ACCPA advice to ensure that the ANAC funding model reflects the actual cost of delivering care, and that may include and reflect that increasing cost of agency staffing when it provides its annual pricing advice to government in the near future.
Okay, all right, thank you. And thank you for being so comprehensive in your answers. Really useful, and I know it's appreciated by the people watching. Danni, I'm going to head back in your direction. I want some practical advice from you. You mentioned mentorship programs, and I wonder whether you can unpack that concept, because you were obviously a convert and you've seen this work really well in practice in the field. Can you just share a few more ideas with us that give those watching some sense of what they might be able to do in that area?
Thanks, Janet. I guess we know as an industry that high attrition rates are a reality for registered nurses. This is particularly the case for graduate nurses. We often focus on the educating of registered nurses, which is very true, but the retention rates are often what really hurt us as an industry, I guess a whole healthcare industry and aged care as well. So we know that whether it be historically, but even more so now when it's a really challenging environment, and I guess people hear a lot of reasons not to enter aged care, that those of us that are in it and know that it is an incredibly valued and impressive career, that we need to do a lot to just make sure that we guide and work with individuals that are coming in so they transition really smoothly. So I think it's that just having that person to bounce off, someone that's there holding your hand, someone that's guiding you when things do occur and challenges occur, that you know that you've got someone to always go back to. I think that's probably why so for even the people and the participants that are in the ACCPA program or something similar like are just having success, and you're just literally getting hundreds and hundreds of successful applicants across Australia, but that then those same applicants don't leave the system, they stay in the system, so it's keeping them in. So I think it's a very challenging environment. Aged care is a little different. When you work in different sectors, you might not have to lead in quite the same way, but when you do come into aged care, probably for all the reasons Melanie's highlighted, you may at times be in autonomous roles. So it's really ensuring that smooth transition in to assist and make sure that we keep those staff that we do get our hands on, because it's a pretty competitive environment.
Okay, thank you. Peter, another one for you. You mentioned immediate and severe risk, and I just want you to briefly outline the distinction between immediate and severe risk and lower levels of risk, because the way you described it, it really was a threshold concern for us. And I don't think anyone online would be surprised to hear that. In the presence of immediate and severe risk, we will move to a different posture and we will not hesitate to do so. Can you just unpack that a bit, please?
Yeah, thanks, Janet, and I'm glad that I managed to make it back in, because I dropped out suddenly. So I've been madly in the background trying to find a solution. So I'm glad that if I'm a bit stilted, it's because I've put myself onto 4G to stay connected. Look, yeah. So what we mean by immediate severe risk, and these terms are interpreted in a common. We are seeing severe risk, and that could be evidence of harm or occurring, or strong evidence that it will occur, and that the absence of any mitigation around that is immediate. So we have actually, we're often out on site, we're seeing these issues, and we're not seeing any evidence from the provider that they are going to put in immediate controls to reduce that level of risk. And so that's where we are seeking to safeguard the interests of residents. So, and in fact, under our legislation, where we see immediate and severe risk, our discretion is quite limited around what powers we can use. We have to normally move to directing a provider to take some form of action, which is what a notice to agree is. So that's the threshold. Below that threshold, there's a lot more latitude. But certainly when we see immediate and severe risk, what we're looking for and what we really need from a provider is that reassurance that they are taking very, very timely action to safeguard the interests of residents, because often we are seeing that risk in relation to some identified residents, and we really do need to see that the provider is taking all necessary action to take those residents out of harm's way.
And just yeah, that's exactly what I wanted. Thank you, because I think the threshold is really critical for people to understand, and that providers are always retaining the decision-making capacity to fix the difficulty or take all the necessary steps in order that they can start addressing the gap that they're experiencing. But absent that effort, we will regard that provider in a slightly different light, and may become increasingly concerned about what's not happening and what appears not to be worked on. Yeah. Just briefly and possibly to close, some reflections from you about the range of information that we use to make these risk assessments, because it's the sources are many and various, aren't they?
No. Look, yeah, as a regulator, we, are very privileged to have a whole range of, real-time information and information that's not particularly old. So we've got information that flows through from complaints. We've got information that flows through from serious incident response notifications. We've got the quarterly information that includes workforce information. We've got increasingly looking at the financial situation of a provider, because that may well be a lead indicator. So we bring all of that together in what we see on the ground through our assessment contacts and through accreditation audits, and also what we know of our engagement with that service. So we don't look at risks through just a single lens. We look at all of the range of issues that may come together and place residents in risk.
Thank you. Thanks, Peter. We're struggling with your transmission, so we didn't get all of that straightforwardly. But one bit I do want to pick up that didn't come through clearly was that you also mentioned in that list of sources of information that we can access information and have a discussion with the provider about financial viability, and that we do some financial monitoring, which gives us a sense of how a service is travelling from a financial standpoint, because we do know, as you said, that it can be a lead indicator of other decisions being made about staffing profile and energetically looking for additional staff to fill vacant shifts. So thank you. I'm not even sure whether you're still online, but perhaps I can use that as the opportunity to close out the webinar. Thank you to all of you who have submitted questions. I'm not sure that we got through the full set, but I know we...
No, I'm here, over.
Good enough job. I'm not sure whether we're receiving you, Peter. I hope that we managed to address your major issues. If there are some that we did not get to cover, feel free to contact us out of session, or we will always be putting information on our website to make sure that we're following up on those matters that may not have had the attention that they need in the course of the last hour. Thank you to all of you for participating. Thank you also to my fellow panel members, Danni, Peter, Melanie, Thea. You've together contributed very significantly to the content of this webinar, and certainly answered all the questions that I was able to get to. I do hope for those who participated that this has been an instructive, educative opportunity for you. We will be providing the link to you after this session, and it will also be available as a recording on our website if you would like to commend it to any of your colleagues as something that is worth watching. This will not be the only time that we are talking about these reforms, and we have manifold opportunities in the coming 12 months to circle back and to add further to the early learning experiences that all of you and we have had as these new reforms have been initiated. So please take the opportunity provided in the survey that will be up on your screen the minute we finish to give us your feedback on what you thought about today's effort, but also what you'd like us to cover in coming webinars, because we are very keen to hear from you to make sure that whatever we deliver is going to suit your needs and enable you to be the high-performing aged care provider that you aspire to be. So thank you, everyone, for your time. We look forward to engaging with you in the new year. Take care. Bye-bye.